So we're just going to set this up. My name is Pamela Matthews. I'm a psychiatric nurse practitioner, and today I'm going to be talking about the gaps in practice that I have noticed. So one of the gaps in practices that I have noticed across the board is that often adults are misdiagnosed with ADHD. And our finding is that only 10% of adults in the US receive proper diagnosis for ADHD. 9 million adults remain undiagnosed with ADHD. Gaps in healthcare settings across the board are screening tools, evaluation practices results in misdiagnoses and no diagnoses. These gaps result in poor prognosis often for patients with ADHD. Why are adults with ADHD chronically underdiagnosed in practice settings? And this is the clinical practice question. The background, ADHD is a complex problem. It is often missed in childhood and dismissed in adulthood. To accurately diagnose adults, there needs to be evidence-based practices and screening tools must be used as well. More on the background history, children with ADHD will continue to have it into adulthood. Adults with ADHD are often underdiagnosed. This can lead to substance abuse, hindered academic performance, alcohol abuse, job loss, and despair many times. 40% of men in prison have ADHD was one statistic that I found. There's also an increased risk for comorbid conditions such as depression, anxiety, bipolar. So the diagnosing and screening for ADHD should be a complete family history, a medical history, a relationship history. Oftentimes we'll find that people with ADHD, particularly the impulsivity type, will have problems with rage, and other family members will be kind of upset about this. The criteria should also be outlined in the DSM-5. And we should also, as practitioners, be aware of evidence-based screening tools. 3 main screening tools used for the ADHD population are the adult ADHD self-report assessment, the Conners Adult ADHD Rating Scale self-report, long version, and the Brown ADHD assessment. So here's some evidence-based practice interventions. So DNP practitioners should be well-trained. They should teach others the correct evidence-based practices. They should lead the charge for comprehensive diagnosis of ADHD, enabling practitioners to rule out any comorbid conditions. The DNP practitioner working with mental health populations should guide the evidence-based practice tools. And this would be asking family members, screening for genetic traits, following the DSM-5 criteria, and noting 18 symptoms with 3 core features: inattention, impulsivity, and hyperactivity. So these are correct interventions to ensure using evidence-based standards for diagnosing ADHD. One would be the use of the ADHD self-reporting scale, the Conners reporting scale long form. Both of these scales would be considered gold standard. Another thing that should be looked into is what kind of medications were they on in the past? Do they have a history of stimulant medications? Practitioners should also conduct a mental health assessment and maintain the DSM is the gold standard for diagnosing. The problem statement: in adults with ADHD, does proper diagnosis using the ADHD assessment scale self-report versus those adults with ADHD diagnosis and other assessment tools predict the same accuracy with diagnosis and treatment as those diagnosed with adult ADHD assessment scale self-report in 1 year? The theoretical for this framework for this project is Pablo's middle range theory of interpersonal relationships. It is used for professional nursing to focus on the patient and nurse relationship. This relationship is essential to gain trust and insight into the patient when asking assessment questions, evaluating the patient. This is all part of the process of receiving an accurate diagnosis. When using Pablo's model, the DMP project supports the patient's perception of care, their values, their needs, and assists the patient in maintaining stability on the medication and affects them emotionally and physically. The use of Pablo's model places an emphasis on trust in relationships as the key to improving care through promoting connection with the patient-centered care as a critical component for effective caring and understanding of the patient. Well, the theory of Pablo's influences the SPP project. It should be noted that the Johns Hopkins model provides a cohesive framework, a conceptual framework for the SPP project. The Johns Hopkins nursing evidence-based model offers a systematic framework for the SPP project. The PET model that it's termed is the practice, evidence, and translation, which provides an organizational body for the SPP project and encourages questions to strategize the SPP using evidence-based findings. And here's an example of the PET model. Practice questions and project planning clarifies the practice question, problems, and also answers who are the participants. So the evidence-based practice model. The Iowa model of evidence-based practice to promote quality uses a flow chart. It identifies problem-focused triggers to identify any clinical problems. The Iowa model then asks knowledge questions using national guidelines or standards of care to identify clinical questions that are important or relevant. If the topic is deemed important, then a team is formed. And when the team is formed, then the team reviews and determines whether this is important. So this is the other layer. And if it's important, then a pilot is formed, and the pilot would test the problem to study the phenomenon further. If there's no correlation formed, then they would kind of step back and look for more ways to check for evidence or conduct the research differently. Is the change appropriate? Then the options were to institutionalize these changes. And then there's still an ebb and flow where there would be a process of evaluating the changes and looking at the outcomes and reassessing things. This is a continual process. So outcomes and objectives. The outcomes and objectives are based on the systematic research, which is summarized beyond current findings for the subject to the SPP to improve practice standards and accuracy, in this case, for the accuracy in diagnosing adults with ADHD. And this would be something that would be considered a standard that would be reproducible in healthcare settings. The objective is a solution that creates a system of change that can be repeated and is transferable to other systems. And it's noted for all overall improvements. It uses specific assessment tools and guidelines for accuracy in diagnosing ADHD applicable across healthcare settings. And the last two slides are my references. Thank you for listening to me. If you have any questions, please let me know, and I will follow up in the discussion.